everyone. Thank you so much for being here. I'm not going to force you to look at me like that. My name is Scott, and I am from Crown Heights Mutual Aid, and we would love to welcome you and thank you for joining us here. A lot of you are in New York, and some of you are zooming in from outside of New York, and we think that's really amazing. This, of course, is a panel we are calling Health Justice, Policy, and Community Care. I'm here just to introduce today's conversation and get us started, and then we'll turn it over to our panelists and to our discussion. So in this call, we have many members of Crown Heights Mutual Aid, but we also know that many of you are from outside of CHMA, and we think that that is a really amazing thing. We're happy that you're all able to be here with us from wherever you're coming from. A little bit of background. Crown Heights Mutual Aid was formed in March 2020 in direct response to the COVID-19 pandemic. We do a multitude of things, including delivering groceries and offering direct financial assistance to our neighbors that are in need. Like I said, a couple of housekeeping things. First, we want to remind everyone that the entirety of this call is being recorded, including the Q&A, and that's so that we can hopefully save it as a document for others to check out after we're done this afternoon. If you're not comfortable with being recorded, you're totally welcome to keep your video off the entire time. And if you'd like to ask a question, but you don't want to speak on video, you can DM your question to myself or to Danny, and we'll make sure to offer it up in the discussion. Also, the recording of this is going to be transcribed, and captions are going to be added to the recording as well. We want to also make a note that health justice absolutely includes disability justice, and that in future events like this, we definitely hope to collaborate with others to offer some sort of live interpretation. During the Q&A today, we definitely want to be clear that we're going to be using Progressive Stack. Progressive Stack allows us to adjust the order that we discuss questions and offerings so that we hear earliest and most often from those whose communities are systemically marginalized. And as the discussion continues, we're going to keep reshuffling the stack accordingly as we go. Since we are having a discussion today, I want to also go quickly over some of our community agreements that CHMA sticks to for all of our meetings. We'll try to make these quick. We have a few of them. First off, one diva, one mic. We don't talk over each other. We don't interrupt when we're having a meeting. Next, no one knows everything. Together, we know a lot. The more people and perspectives that we hear from today, the more that we're going to learn and the better our projects are going to become. Next, speak from your own perspective and experience. This is especially important today as we're talking about things like healthcare and insurance and our own experiences with the system. So try to use I, not we statements, and don't assume that everyone is already on the same page or knows the exact same sort of perspective as you. Next, be aware of time. We're going to do our very best as facilitators to keep the discussion and the panel to what we said, which is about 75 to 80 minutes. And we'll try to keep that on track for everyone so you can enjoy the rest of your afternoon. Our next agreement here, embrace curiosity in what you offer. So if our discussion ends up going somewhere unexpected or we get a little quote unquote off track, that can be okay. Acknowledge the difference between intent and impact. The things that we say sometimes land differently with listeners than what we intended. And the other way around, the impression that we get from someone's statement might not necessarily be exactly what they intended. So just try to keep that in mind as we're talking to each other. Just a couple more here, move up, move up. If you're someone who often speaks in discussions, consider hanging back a little bit and letting others go first. If you're usually not so vocal in this kind of space, please consider hopping on stack and speaking. We want to hear from everyone today. We can't be articulate all the time. That's okay. I certainly can't. If you don't have the perfect phrasing for your comment, don't worry. If you lose your train of thought, that's okay. We'll want to hear from you no matter what. Finally, in Crown Heights Mutual Aid, and definitely in this space, we do not tolerate racism, sexism, classism, ableism, or bigotry of any kind. And if you witness or experience any of these forms of abuse, please feel empowered to address it directly. So before I introduce our first speaker here, I do just want to, on a personal note and from the Education Working Group of Crown Heights Mutual Aid, say a thank you to all of you that RSVP'd. Those of you that told friends about it, those of you that shared this info in your other groups and organizations, you really all made this event possible. We want to thank you for trying something new. This panel is a first sort of open discussion event that Crown Heights Mutual Aid's Education Working Group has held, and it's our first healthcare focused discussion that we've had. We know topics like getting sick, paying for insurance, living with medical debt, the daunting politics of how to fix all this stuff, they're not always that easy to talk about, and we know it can be stressful, and we know it can be personal. And so we're grateful that we're here sharing with you in this conversation and this space. So now it's my pleasure to introduce Tim. Tim Faust, his writing has appeared in Splinter, Jacobin, Vice, and other publications. He has worked as a data scientist in the healthcare industry. And before that, he enrolled folks in the ACA programs in Florida, Georgia, and Texas, where he saw both the shortcomings of the ACA and the consequences of the Medicaid gap firsthand. Since 2017, and at least until the pandemic, he's been driving around the United States in his 2002 Honda CR-V, talking to people about health inequity in their neighborhoods. In 2019, Tim published a book, Health Justice Now, which I can personally attest is a really informative and incredibly enjoyable breakdown of health policy in America and how it intersectionally connects to things like housing, race, class, gender identity, and environmental justice. Tim lives in Brooklyn. Tim, you have the floor, and after we're done, we'll have our first round of Q&A. Like I said, everyone's welcome to type questions in the chat or just type stack if you'd like to speak your question. That's totally cool too. We'll keep track of them, and then once Tim is done speaking to us, we'll kind of turn right into Q&A. So take it away, Tim.
Cool. Thanks, Scott. Thank you, Crown Heights Mutual Aid. Thank you, everybody, for having me. I really appreciate it. I'm normally accustomed to giving talks, in person, so this is an adaptation to the talk I used to give when I traveled around. So please forgive me if it doesn't quite translate into cyberspace, but we'll do our best. I want to talk about kind of the lay of the land and why healthcare is so expensive. And then I'm going to speak briefly about single payer and what it is and what it does. And then I'm going to talk more broadly about a bigger vision, one of health justice, which ties together a lot of the shared struggles we all face as we navigate the travails of being human. All right, so let's start off with some fundamentals. First off, nobody can afford to pay their medical costs by themselves. Medical care is extremely expensive. But generally speaking, not a lot of folks need it at the same time. In a given year, 50% of all medical costs come from 5% of the population, a population which someday you will join, right? Eventually, your day of tragedy comes, and when it does, the medical costs will be enough to destroy you. That's why we have the concept of insurance. Insurers pool together money from a lot of people to pay off medical costs for those who need it. And the larger this pool of people, the wider it can spread costs and the lower the per person cost or risk. In the US, we mostly delegate the business of insurance to private insurance companies. Insurance companies charge us monthly premiums to build their risk pool. And like any company, their job is to make money. So if an insurer has too many people who use their insurance plan to seek medical care, or too few healthy people, or too many sick people, just one person with hemophilia, for example, can cost over $1 million a year to insure, its per person costs really increase. And so to compensate, it increases premiums. But when premiums go up, customers who can't afford them drop out. But sick people, expensive people, can't afford to drop out of their insurance plans because they need the insurance. So you've got a customer base that is sicker and sicker, and therefore more and more expensive per person, leading once again to higher premiums. It's this big, stupid Ouroboros of misery. Thus, generally speaking, unless the government is subsidizing them, which they often do, an insurer wants as uneventful or healthy a customer base as possible, or wants to find ways to kick out sick customers or coerce them into leaving. Maybe it drops coverage for drugs sick people need. Maybe it cuts off access to doctors who treat sick as patients. Maybe, and usually, it does both. Because insurance companies don't lose money when you get sick. Insurance companies lose money when you get sick and then you use your insurance plan. And there's nothing they could do about it, even if they wanted. If insurance companies were to offer the care people needed where they need it, or if they were to offer it at rates people could afford, sick people would then buy the insurance plans and then use the insurance plans, and the insurer would lose money. In some healthcare markets, we spend billions of dollars of public money a year bailing out insurance when this happens. And so this commodification of healthcare reduces health to a financial transaction or an investment vehicle instead of a connection or relationship between a person and their body and their doctors and their community. That's perverted. We've mistaken the profit motive of corporations for healthcare. So that sucks. That's one side of the coin. But it gets worse. I mean, of course it gets worse. This is the beginning of the speech. I've got more to go. Because the costs of healthcare keep increasing. Most of these cost increases occur because hospital CEOs and pharmaceutical companies, our close personal friend Martin Shkreli, keep finding ways to charge more money for the same services or rack up fees for unnecessary services and no private insurer can stop them. Fundamentally, in the US healthcare market, all prices are fake. They're just totally fake. Here's an example. In the US, the average inpatient procedure costs 40% more than the exact same inpatient procedure when performed in France. Or think about MRIs. You all know MRIs, they're big fancy tubes that print money. In the US, an MRI scan costs 5 times more than the same scan when performed in Australia. But it gets even dumber closer to home. Sometimes MRI scans from the literal same machine at the literal same hospital have a 7-fold cost variance based upon who's paying for it. Prices are totally fake. Over the past decade, we've seen the price of insulin triple. Not because of new costs to produce it, but simply because insulin manufacturers like making more money and nobody can stop them from increasing their prices and charging as much as they can. Most frustratingly, consider the relationship between primary care and hospitals. Primary care is things like checkups, basic medications, the kind of familiar, intimate healthcare you get from your family physician. It's high volume, it's low margin, and generally it's not super profitable. But now conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So if you're a hospital CEO, it just makes a lot more sense to push folks into inpatient care instead of wasting your time and minimizing your profits by letting them get cheap primary care outside the hospital. Or it makes even more sense to buy up all the cheap primary care clinics and either close them down or use them to charge hospital rates, which is what they do. Well, what's that mean? That means that 58 million Americans have no access whatsoever to primary care. So as you can see, these are the two fundamental but opposing truths of American healthcare. One, if you're an insurance company, it's just not profitable to insure sick people. Two, if you're a provider, like a big hospital, it is extremely profitable to charge sick people as much as possible, as often as possible. Now, this whole situation scares the bejesus out of everybody involved. It's not sustainable, particularly for the insurers. Insurers are interested in finding ways to mitigate these rising costs and avoid paying these costs. Often that means just refusing to pay for claims they don't want to pay. It's probably happened to you. But that by itself is enough to claw costs down. So back in the 1970s, we all invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just a libertarian way of saying people, pay more for the costs of their own healthcare, which is why your deductibles and copays increase every year to mitigate rising costs and make sure you put more of your own skin into the game, which is horseshit. All this does is help insurance companies pay out fewer claims because people who are forced to pay for healthcare costs they can't afford just don't seek healthcare. We've decided to punish people with healthcare costs they can't afford under the guise of making healthcare a matter of personal responsibility. Also, that hospital CEOs and insurance CEOs and all their friends can bring home millions and millions of dollars a year. But at the end of the day, costs keep increasing and quality of care stagnates for the most vulnerable among us. Our health finance model takes money from the poor and gives it to the rich. It is literally negatively redistributive. In 2014, it pushed 20 million people into poverty. 31 million people are left uninsured. Now, we're in the middle of a goddamn generational pandemic, and we've got folks who are worried about getting the virus, not because they'll get sick, because they'll go bankrupt, or worse. The American model of health has failed. And among so-called developed countries, it is America that is the most dangerous place to be sick if you're poor, because rich people are exempted from all these problems. Men born in the wealthiest fifth of America get to live 15 years longer than men born in the poorest fifth. Among women, that gap is 10 years. We have chosen to let poor children die from things which rich children do not die from. I think this is war. This is the terrible secret of American healthcare. This is the fundamental American illness. They are killing us and robbing our corpses to foot the bill. And so this big, stupid, multi-payer, profit-driven Rube Goldberg machine of American healthcare is failing us today, and left unchecked, will collapse tomorrow. It's not sustainable. It will collapse. So we demand something different. We demand a federal, universal, single payer, also known as Medicare for All. Single payer is a pretty simple concept. We pool together all the money we're currently spending on healthcare to cover in full all care for all people. That's comprehensive coverage, medical, dental, vision, and long-term care for all people in America, including non-citizens, that is free to use at the point of service. America is already spending the money required to fund single payer. One study claims that single payer plans before Congress would cost 10% less than we're spending right now. Single payer lets us liberate people from medical costs and reallocate the spending to take care of everybody long term. Part of the reason costs are so high is because private insurers, with their relatively small customer bases, just can't negotiate with big hospitals and drug companies. But once Medicare for All represents 330 million people, it basically sets its own fair prices for care because it's the most powerful negotiator around. So these wildly inflated costs get their balloons popped and are brought back down to earth, and then we're playing on an even field. But even before that happens, we free up all the money associated with admin costs and profit within the private insurance market. This optimization opens up, in a conservative estimate, an additional $370 billion a year. 370 bundle, that's a big chunk of change. What do you do with it? You use it to improve everyone's standard of living. You build or reopen primary care centers in rural areas. You fund community health clinics in poor neighborhoods. And most importantly, you return the money to the people who do the work who don't get paid enough. Because think about it. Who makes a real difference? What makes a real difference in health outcomes? Is it luxury hospital suites? Is it millionaire or multimillionaire surgeons? Is it $40,000 data packages for nerds to look at? Is it apps? No, of course not. Those are just the folks who get to build the most. What makes a real difference is extra clinical care or compassionate labor. It's social workers, patient advocates, vaccination counselors, nurses. These are the people chronically unrecognized and underpaid, and they're the primary people who make a difference in population health. We waste hundreds of billions of dollars a year in healthcare system waste, and 100,000 people are employed to pick up the mess. That's money we could spend training people to perform work that actually helps the people around them instead of shoving them around. I mean, the things that make us sick, the things that send us to the hospital, don't always come from viruses or bacteria. More often than not, they come from unsafe housing, or no housing, or unsafe food, or deprivation of the social services required to keep a person and their community healthy. These are pretty basic ideas. These are pretty simple demands. We already understand the social forces that make people healthy, and we understand the structural ones that make people sick. But in the multi-payer private model, nobody's investing in long-term health. Nobody's investing in population health. Nobody's investing in compassionate labor or paying those people fairly, and they just never will. Let me put it another way. You know that if you're at home and your window breaks, the weather gets in. And if the weather gets in, too hot, too cold, whatever, you get sick. And if you get sick, your kid gets sick, you got to go to the doctor. But if the local clinic was shut down or it's booked solid, you got to go to the hospital. And if the hospital's far away or you don't have a car, you got to take the bus. And in a lot of places, if you got to take the bus, you got to spend the whole fucking day dealing with the bus system. If you got to spend all day dealing with the bus, you can't go to work. You can't go to work. You don't make any money. You don't make any money, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a big pile of cash every time you go to the hospital. The answer begins with giving people what they need to fix the goddamn window. But there are no private actors in the American model who will bear responsibility for fixing these problems on their own. But we can, and we will. Because once the federal actor, once that single payer bears the costs of providing care and the costs of what happens when care is not provided, once we force it to confront the rampant suffering of all its people, we begin the work of finally using it as a tool for realizing health justice. If your people are getting sick because they don't have a place to live, or the places they live are unsafe, then housing is healthcare, and you build safe social housing to bring healthcare costs down. If your people are getting sick because they don't have access to healthy food to eat, and so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you provide people with affordable or free food options to bring healthcare costs down. If your people are getting sick because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And you build full cycle addiction treatment programs to bring healthcare costs down. Because single payer, which I love, is not the goal. Single payer is only the tool. Health justice is the goal. And when we fight for health justice, we all fight side by side, because Economic justice is health justice. Environmental justice is health justice. Reproductive justice for those who don't want to reproduce and those who do is health justice. Just wages and just working conditions is health justice. And justice for Black lives, justice for trans lives, justice for the lives of immigrants, justice for brown lives, justice for people in prison, and the well-being of all people, regardless of age, gender, race, or creed, that is health justice. We have inherited a world in which your permission to receive healthcare, your permission to be safe in your own goddamn body is dependent upon how much a corporation can extract a profit from you. And thus we have permitted in our country utter desolation. And nowhere is that desolation more clear than in the prison system. One thing I haven't discussed much is mental health. So I want to talk about Houston, where I lived for many years. And you can't talk about mental health in Houston without talking about Harris County Jail and how it's the largest quote unquote provider of mental health services in all of Texas, which is a fine observation and it happens in every state, but reality is a bit more complicated than that. Most of you probably know where that's going. In Houston, people who are arrested and suspected of having mental health issues are held in these dark, dank, dungeon-esque cells in the Harris County courthouse. You would not know these cells existed unless you were looking for them. So if you're a person with mental illness who's been locked up for a few days for things like trespassing or disorderly conduct, what do? You haven't had your medication while you've been locked up, so you got two choices. Plead guilty and you might get out on time served. Two, fight it, looking at more time locked up without your meds. And this is if you're lucky enough to pass as functioning normally. If you're in the middle of a serious mental health episode, things get worse. Then you're held for up to 30 days until the county gives you a session with a psychiatrist. People are held in the hospital wing of the prison or the prison wing of the hospital. There's this concept of a prison to hospital pipeline which comes up when discussing mental illnesses in jail, but it's not a pipeline. Pipelines go in one direction. It's more like a pinball machine. Giant invisible flippers bounce people between jail to hospital and hospital to jail and jail to hospital, and at some point there's just no functional difference between the two. We refuse to care for people, and so they become sick. We make them sick. And if you're the wrong kind of sick, or if you're the wrong kind of person, we delegate your care to prison. It's technically not a crime to be poor. It's technically not a crime to be sick. It's technically not a crime to be black or brown, but once you fall into the intersections, the rules change. If you're a poor single mother, poor mother of color, for example, you have virtually no right to privacy. If you're in Section 8 housing, a state agent comes to your apartment twice a month and counts the shoes on your shoe rack. And if they find too many shoes, or if you're a single mother and they find a man's shoes, you can lose your benefits. If you're disabled and on Medicaid, every month a nurse comes to your house to check to see if you're still disabled or if you're faking it. And you only get to go through this deeply humiliating process in the first place if you're poor enough to qualify for Medicaid long-term care benefits in the first place. And some states need to make less than $2,000 a year. If you're a Medicaid recipient in a work requirement state, every month you got to wait in line for hours in an intentionally understaffed office to prove that you're employed. And these processes drive people into the streets, into the hospital, or into jail. Now, so long as we use prison to hide those who are made undesirable by their healthcare needs, healthcare and prison are inseparable. So while the idea that prisons are the largest providers of mental health and healthcare in the US is a well-intentioned and technically correct idea, it's wrong. Because no prisoner will ever receive the care, support, or resources they need to handle whatever's fucking with them. And no prisoner will ever be saved from the inevitable return trip home, or the inevitable return trip once they get out, get home, and remain sick. Because prisons are not hospitals. Prisons are warehouses for the ill. They are storage units for the unwanted. And so I want to be explicit. Insurance is not enough. Our goal is not simply insurance, but emancipation. We must put the people who have been most harmed at the front of the line. We must walk together every goddamn step of the way. We must never compromise until we all have been liberated. Our health is apportioned to us along the lines of structural poverty and structural racism. Our American body has been poisoned by the wicked snakes of racial and economic and patriarchal domination. And these are problems private insurance cannot fix, will not fix, and in some cases has caused. These are the problems which can only be addressed with the full force of all America's people, our bodies together, forming the shape of our government, armed with a single-payer healthcare system. There's a little truism that you can predict someone's life expectancy by using their zip code. Our cities are racially segregated, and that segregation causes disastrous long-term health consequences. And even if you're spared that burden of segregation, if you're a person of color, you still get worse care in the hospital. Single payer can't fix that on its own. But single payer gives us the foundation upon which you may build the comprehensive community and racial justice movements we need. Because single payer is not the revolution. It's our first counterattack in the war that is already waged against us, by which subsequent counterattacks are made possible. I reckon our job is not to build a single popular movement. It is to stitch together a popular movement, a big messy quilt of fights for health justice in our factories, in our offices, in our churches, in our dive bars, in our mutual aid organizations, spanning the country from coast to coast and plains to Gulf. Here's an example. In Austin, they used money they took from the police to buy a hotel that can now house 60 people and give them social services. That's health justice. If we give people something material, they will fight to keep it. If we fight with people today, they will fight with us tomorrow. We build solidarity so we can build power. And through these kinds of popular massive mobilizations, and only through these kinds of massive mobilizations, this is a fight we can win. I believe this nation owes its people, whose labor has created its rich banquet, the safety and agency of healthcare. I believe this healthcare is greater in scope than that which happens upon an operating table. I believe that housing and food and income and more, the components of basic human dignity, are healthcare. And I believe our work is that of striving towards justice for all people. And I therefore believe, I have to believe, that single-payer healthcare, Medicare for all, is our moral imperative. Single payer is our tool. Single payer is our weapon. Single payer is our first step. But single payer on its own is not the goal. My friends, single payer is moral, single payer is necessary, and single payer is achievable. Solidarity now, solidarity forever. Thank you.
That was amazing. Thank you so much, Tim, for that. I see a lot of claps in the chat. My name is Danny, and I'm with Crown Heights Mutual Aid as one of the co-organizers here with Scott, in the Education Working Group. I'm going to facilitate discussion here with Tim, and if you have specific questions, please drop them into the chat box. Like we said earlier, we're going to try to maintain a progressive stack to ensure equitability and inclusion. And so I will now turn to the stack, and if anybody has a question, please drop it. And Tim, you can read it yourself, or I can read it aloud for the group.
Cool.
I can also start us off here. We're still kind of absorbing a lot of those points.
First question is, what is the likelihood of single payer during Biden? Well, frankly, I don't know. Depends on how hard we push it. What I can tell you is we've got a couple options that Biden's already talked about, and some of them are better or worse than others. Right now, his big plan is to further subsidize private insurance companies, COBRA, and through the ACA expansion. And that's not acceptable. That's just kind of offloading our problems onto private insurance companies and giving them billions and billions of dollars to make profit off of. And that's not okay. There's other options that are on the table, like expanding Medicare to people age 55 and above, which is imperfect. And frankly, there's a debate of whether or not the trade-off of giving people healthcare now through Medicare expansion versus fragmenting the movement, because people who get healthcare might not want to fight for people who get healthcare who aren't them, for example. But I don't really know where I fall on that. What I do know is that programs like expanding public programs like Medicare, ideally giving people 26 and under, 26 and above everybody, but where you can get it, is a good way to kind of build the platform for expanding Medicare even further in the future. I think that's more feasible under Biden. But I think regardless, this isn't a thing that's measured like on a 2-year timetable. It's taken us 30 years to get to, I think, the end of chapter 1 of Medicare for All, which is having 2 viable and discussed bills in the House and the Senate. This is a long-term fight. I think building that big popular movement will get us, give us a platform to demand Medicare for all, whether it's from Biden or the next person or whatever, right? We got to build the fire. And so there's a what can we do under Biden? I think you can both organize for the thing you get under him, Medicare expansion, while not letting go of the long term thing, right? These are nested goals. It's a little matrishka of organizing. You can demand the thing now that helps people and use that to turn out people for the next fight. So I don't really want to predict whether or not single payer happens under Biden. It seems to be not likely, but I don't think it's a reason not to keep organizing for things that contribute to the broader fight.
Awesome, thank you. Stack is open. I have a question though while people are thinking. So even with clear economic and moral arguments against the privatized system, which you laid out so well here, in your opinion, what are the main obstacles to implementing a single payer system? Who are the actors? What's the fight? How do you see that landscape?
It's money, baby. It's the guys that it's people that got paid. Big bad guys, the easy ones are AHIP, America's Health Insurance Programs, and the AMA. And pharma and all the other like lobbyist groups. Medical devices have one called MDMA, which I can't believe they got the acronym for. But those are the folks who have all the money and were organizing against things like single payer. There were people who beat it down in the 40s and 50s, people who beat it down in the 70s and the 90s, people who shut the public option in 2010, and they're the bad guys. And frankly, like we can't outspend them, right? They've got unlimited money. They have more money than God. And even like a well-funded candidate, even Bernie Sanders couldn't afford to go toe-to-toe with those guys. The only thing that can beat them is turning out massive people in the streets. You got to be able to fight for this thing in the streets to demand it. Which I think is possible. I mean, one of the reasons Medicare was won is because seniors turned out in droves and stormed DC, stormed the streets. There was a bunch of really successful seniors organizations that won this thing by hitting the road and demanding it. They bust down from all over the country and make people's lives miserable until they did it. You can look at ADAPT, for example, which is a disabled person program, a program of disabled people with disabled liberation. They fought against the Paul Ryan ACA replacement bills in 2017, which seemed so long ago, by going to DC, putting their bodies on the line. I mean, there's people getting pulled out of their wheelchairs and getting thrown into jail vans and driven away and coming back the next day. Well, that's the kind of fighting we need. And pharma and the AMA can't beat that. And we've all got our own little places to plug in, right? I think the AMA, that's the domain of doctors and med students. And we're seeing progress in that front. This is the first year that the AMA decided not to pass a resolution explicitly condemning single payer, which is, kind of a small goal, but a big one considering how long it's been opposed to this thing. That's because young doctors are coming out of med school and organizing among the communities to fight for single payer. Like, if you're in med school, for example, you're told that healthcare is apolitical, which is of course bullshit. That's the thing they tell you. You're told not to look behind the curtain to see why people get healthcare, they don't get healthcare. And we're seeing that kind of begin to erode because the politics of healthcare, the politicization of healthcare is becoming more and more naked and harder to cover up. So you've got groups like SNAP, Students for a National Health Plan, that are growing and organizing on their healthcare campuses. And you've got kind of things like that happening. I think like these are the bad guys. The only way to beat them is with our feet. They've got unlimited money, and so we've all got to kind of find the things we can do and push against that.
Thank you. Open stack for anybody who'd like to ask a question.
I can make up some questions.
That's fine too. I have a few sitting here.
There's one that I get asked a lot that I think was Scott gave me some pre-questions that some people had written down, and one of them that made me think about it, that I can answer pretty briefly, is like right now the healthcare industry has a lot of, I don't want to say useless labor, but healthcare labor that we would not need under single payer. For example, medical scribes, billing assistants, people who work at insurance companies, and it's like putting together all the little strings of billing structures and all these little financing things. And I think there's some pretty easy answers. And that answer is social work. There's all kinds of things you can do to help people around you with your labor, as opposed to kind of needling them through insurance jobs. Here's an example. There's a model of healthcare called the medical legal partnership. It's a model that was pioneered in Boston, because every now and again a good thing comes from Boston. And here's how it operates. And so this is a real example. My partner used to work at this. A person comes to the clinic with their kid and says, "Hey, my kid is sick. We don't have insurance. We're on Medicaid. Can you help us out?" Behind the desk is a social worker. The social worker says, okay, you need medical care. Let's send you over here. The nurse will treat you. A doctor will treat you. Okay, your kid has asthma. Okay, cool. We'll give you a prescription for an inhaler, send you on your way. No, the social worker says, well, hang on a second. Asthma in kids, this severe, is often caused by other kinds of conditions. So what's happening at home? And the patient says, oh, well, we live in the projects. There's mold in the ceiling, there's mold in the walls, there's water in the walls, and we can't do anything about it. The social worker says, oh, people get sick from that kind of thing. Let's kick you down to door number 2. And behind door number 2 is a lawyer. And the lawyer says, oh, you've got certain rights as a person against these kind of conditions that make you sick. We're going to go ahead and threaten to sue your landlord. Here's a letter. We'll mail it in. What do you know? Within a couple of months, the apartment had been fixed up. You've got all these rights you're entitled to as a person, but you only have access to them if you have the money or the privilege or the time or the legal literacy to pursue it yourself. There are models of healthcare where we work together to kind of build these infrastructures and tie them together. But at the core of it is social workers that do the work of taking people in, hearing their problems, and navigating them around the structures that they need. Right now, a major component of insurance labor is customer support centers. Their job is fundamentally to take somebody who needs healthcare and find the minimum amount of healthcare you're required to give them. Kind of push them into a chute and kind of bounce them around, even if you don't want to. It sucks. I work with people who work in healthcare customer service, and you feel bad at the end of the day. You can't help people with what they need. But under single payer, suddenly you've got this massive need to help people get the healthcare they need as soon as they can get it and get the things they're entitled to help solve their health problems ahead of time. So you can kind of take those folks and it's a simple transition of their labor, turn them into people, you can turn them into social workers, care workers, navigators, counselors. There's all this kind of work a single payer needs to become healthy and to sustain itself. And I think we've got a pool of folks who are eligible. We've got the money to train them. That's a big part of Bernie's bill. We've got the jobs that are required. So I think there's a pretty easy transition of folks from insurance into the single payer. And if not, Bernie's bill guarantees a lot of money to transition people into other sectors.
Awesome, thank you. We have a question from Sam. I can read it aloud here. Given our government's track record on just about everything, how do you think we can account for or protect against injustice in a single payer based around the idea of medical necessity and the procedures and communities that are often left out? How do we make sure trans and disabled folks have power at the table, for example?
That's a great question. It kind of goes hand in hand with the question of why should we trust the state to begin with? And I think the answer to that is, well, right now, these decisions are all made by private companies, right? And you can't organize against them. You can't vote out Jeff Bezos. You can't petition the CEO of Cigna and hold them accountable. That's why single payer is a first step, not the be-all and all solution. What we want is fully democratized healthcare where people get what they need. I think single payer gives us the platform to kind of build that thing where our healthcare is navigated for people that we have access to and power over. And I think while single payer doesn't solve that problem, there's still a lot of problems with the state and healthcare. The state has a bad track record when it comes to racism and ableism and discrimination in healthcare. But I think only through a democratized healthcare movement can we really begin to push back against these things. As far as medicalization and necessity, these are complicated. But again, these are choices made by public entities that we, in theory, can organize against and push back against, whereas right now, made by private actors with some federal regulation. For example, the medicalization of trans healthcare is really complicated, right? You don't want to make it a medical disorder because it's not, but at the same time, like you don't want to it's medicalization, I'm told, is not necessarily the right avenue for trans healthcare. So how do you make that a thing you get instead of making it like a disorder you need to get diagnosed with? I don't know. That is a big question, but the answer can't be through letting private companies handle it. I think the answer is through building a popular movement, building a democratized Medicare state, and organizing to keep the pressure on. Because we're gonna have to organize massively to get the thing in the first place. I think you can transition from that movement into building the list to keep it accountable, and then the folks that write the regulations are kind of the people who need the healthcare.
Awesome, thank you. We have one from Madeline, or Madeline, apologies. The question is, where do you see newer companies like Oscar or Capsule fit into this future?
Leeches, parasites, vultures. I work at Oscar, full disclosure. I'm trying to quit. I have a new job. I had an interview yesterday for a new job, so inshallah, I'll be free of that. Oscar is just an individual insurance company. They've got better technology. They have better tools, but they're still, at the end of the day, not paying claims they don't need to pay. They're not paying claims to see what happens, not paying on surprise bills. It's still an insurance company. It's still a vulture. It's still a parasite. Capsule, things like GoodRx, these are companies that are not exploiting, they're doing things that are useful, but they're only useful because our system is so fragmented and bad and broken that they're finding the gaps and kind of wheeling their way in there. You know, cool that you can get cheaper pills through GoodRx. I use it a lot, but bad that it needs to exist. So I think these are the kind of things that get excised and transitioned to. Like, there's still a lot of cool things you can do alongside a single payer. I guess you can build programs and become a contractor, but I don't think these things are part of the future we want under a single payer program.
Great, thank you. Okay, we have Lauren next. Question reads, this is kind of an existential, maybe unfair question, but COVID seems to be the perfect landscape to make the moral and material argument for Medicare for All. What kind of political will do we need to foster / what kind of organizing do we need to do in order to turn people out en masse, especially when the crisis is so particularly clear right now?
It's a great question. Sorry, the sun is directly, I'm going to close this thing. There we go. That's a good question, and frankly, I don't think I know the answer, right? Like, how do you build a national movement is one that I think we've yet to really crack. The shortcut was the Bernie campaign, but you know, they beat us. I think the thing that does work is building local movements now and bridging them together as they move forward, right? Like, we've seen, for example, the Black Lives Matter movement and the things that happened in June and July turn into programs to decarceralize and defund the police in cities all across the US. As I mentioned in Austin, they just used money they took from the cops to buy hotels to put unhoused people in. Like, these are things we can do. That movement will continue. It's like a stone rolling downhill. And so how do you build a national movement? I think the answer is you build a bunch of small movements that bridge them together locally. I know you've got the NYC DSA healthcare working group here. I think, for example, the things they do kind of build, like the emergency healthcare working group, or the healthcare emergency bill that Jayapal and Tedder put forward. I think things like that, organizing locally for that, organizing locally to decarceralize and defund our own police and carceral healthcare programs. I think that's how you do it, right? Like, we've got like the naked moral horror of the pandemic, and people are being thrown under the bus because they can't afford it in the first place. I think that builds fuel. People are ready to be talked to. We've got to find things we can plug them into, and you build a thing you can locally, and I think bridge together off of that.
Great. Next, we got Steve. Question reads, what would you say to members of the disabled community who are on the fence for Medicare for All because of their fears from poorly run Medicaid services?
So Medicaid is a pretty gnarly program. Medicaid, Medicare are very different, right? Medicaid is state-run. States pitch in some portion of the money for the services. The federal government pitches in the rest, but administration of the states are much more cost-sensitive than the federal government is, because states can't deficit spend, for example. The states have all these regulations, and so states are much more likely to try to impose restrictions on what kind of care you can and can't get. It sucks. And especially with disability work and disability care, long-term care, a lot of states, like for example, Jersey is a really bad one, will privatize their Medicaid long-term care. They'll build managed Medicaid agencies that you kind of have to go through. And these people are accountable to nobody, and they provide awful care. I think what Medicare for All does is it removes these obstacles to getting care. It cuts out, it excises the privatized, groups that are kind of getting in the way of this bad care. It relieves states of these cost burdens, which they use as an excuse to kind of squish down upon marginalized people, and provides the full federal funding for all the care you need. Both of the bills cover long-term care in full, especially home health care, which is a really essential component of that, of the disabled liberation movement. I think prioritizing those kinds of care and providing the funding for it's essential, and those things are represented in the Sanders and Jayapal bills. I think we have to keep those in the front of our heads as we organize nationally and locally, because Medicaid sucks for a lot of people. I mean, thank God if you have it, it's much better than being uninsured, but people get squished around and beaten down if they're already being marginalized by private Medicaid structures, and sometimes even the state itself can fuck you over. So I'd say that the answer is, how do you, the thing that we have now is poisoned by the disease that single payer is trying to cure. So if we work to solve the root of the problem, which is this configuration of state spending and budget crisis and the commodification of healthcare, we provide the platform from which we can build a liberation movement that everybody needs.
Nice. Excellent. Okay, next one is from Katie. The question reads, I've generally been disappointed with the lack of labor leaders supporting Medicare for All, considering healthcare tends to be the biggest fight during contract bargaining. What do you think is the best way to approach moving the needle to gain support amongst people who may feel that Medicare for All could diminish the power they've built in the workplace?
Sure, that's a gnarly question, right? Like, for a lot of unions, access to good healthcare plans is like their carrot for union membership, why you should join. And if you take away that, people are afraid unions will lose power or lose a lore or things like that. And I understand that you're kind of suddenly at odds. Two organizations, two movements are kind of orthogonal to each other. But I think the answer is not that complicated, right? Right now, if you're in a union, you got to spend all your time negotiating for a better healthcare plan, which gets worse and worse every single year. And that's time and leverage you can't spend organizing for higher wages, better work conditions, and more safety, a safer workplace. So I think what the message is for unions is that, and for labor is that this takes a huge burden off your plate and frees you up to organize for more aggressive and more important things. It also lets people unionize their workplace much more efficiently. Because right now, a big concern is if I try to unionize, I'll lose my job, I'll get fired. You see that in Amazon. Well, that's a big concern because often your employment is tied to your healthcare, and therefore losing your job means you lose your healthcare and your kid gets sick and you're screwed. I think by taking that kind of yoke off people, by guaranteeing them healthcare regardless of employment, you give people the freedom to organize and fight back and demand more of their employers without the fear necessarily that their kid will no longer be able to pay for their leukemia care.
Thank you. This one came from our RSVPs. In the interim before proper Medicare for All by the government, do you see any possibility for a grassroots, crowd-funded, or mutual aid approach to forming our own health insurance pool and ability to negotiate prices for members?
That was attempted. You've got the co-op insurance movement that was kind of a part of the ACA, and those all failed. You're going toe-to-toe. Like, one of the big reasons that Medicare for All is effective is because it can negotiate on behalf of 330 million people. Like, half the problem here is the hospitals, right? It's not just the insurance companies, it's the AMA, it's pharma, it's the device manufacturers, and massive corporate hospitals that do, like Montefiore, for example, does a hell of a lot to squeeze folks out and charging massive prices. Imanades is another product example. And if you're a co-op, if you're a smaller group, you don't have the leverage to negotiate good prices with those large corporate partners. You just don't. So you get squished, you get run over, your costs get jacked up, and so either you pass on premiums to your members, which is bad. Same thing insurance companies do, where you're full. Like, the reason insurance is bad is like a rational one, right? Insurance companies are rational actors in a massively, like, horribly, like, morally aberrant, like, structure, right? They're making rational choices. It just happens to be that all the choices all happen to be bad ones. But I don't think you solve that through making a small insurance pool. It has the same problems. It's smaller than things like Aetna or Cigna, therefore it falls into the same traps. Unless you can make a co-op healthcare system, make a co-op hospital that can provide appropriate fair prices to that co-op insurance pool. I don't necessarily think that that's an effective way for it.
Great, thank you. This is from Ryan. Slightly different but related. What are your thoughts on getting rid of the filibuster in the Senate? I see it as a main barrier in the way of progressive legislation. I think Republicans like the filibuster because they get to tell their base, whom they know is crazy, that they're fighting on their behalf, but they can't legislate because the filibuster is in the way. The right would actually have to legislate instead of just stoking fear. Do you think this is a correct read on the situation? If you remove the filibuster, do you think Medicare for All is on the table?
If we remove the filibuster, there's fewer excuses of not having Medicare for All on the table. Politicians are confusing to me. I don't trust them generally, and I don't like them generally speaking either. I'm sure with the filibuster, people will find ways to push back against Medicare for All, but I think it makes that contradiction more transparent. It makes it more visible of who the actual. Like right now, you can hide behind the filibuster, hide behind that of the need for reconciliation to justify why you're not supporting Medicare for All. I think taking the filibuster off the table is good for a lot of reasons, but as far as Medicare for All is concerned, makes the playing field more, like it removes some obstacles to seeing who actually is on the side of Medicare for All and who's opposed to it, which is good.
Great. We have another one. Sorry, I'm reading from my phone here. So I work in EMS in rural Appalachia for a company attempting to stand up to a community paramedicine program. I'm also type 1 diabetic and becoming a certified diabetes educator for the purpose of this program. This is the second attempt for this program. Several years ago, our plan was nixed by the powers that be. So what's the role of community paramedicine in advancing health justice? Who will be my biggest enemy within local healthcare systems?
I think honestly, you're better to answer the question than I am, right? I don't know a lot about paramedicine in Appalachia. So I don't think I don't want to tell you how to do your job. I'd actually, if you're here, I'd love to hear more or talk to you after this thing because I'm really, that's interesting. I don't know a lot about paramedicine, and I can presume it's things like ambulance corporations, which are massive cost sinks. It's interesting. There's a big surprise billing bill that was just passed, which prohibits consumers, people, from being surprise billed when they get out-of-network care at an in-network facility. Like, for example, if your anesthesiologist is out-of-network, which a lot of them are, but you can't control who that is. And ambulance care was exempted from that. There's a pretty powerful ambulance lobby, and they kind of worm their way through a lot of these things. And I have to presume they're opposed to co-op paramedicine, but I don't necessarily know the contours or the intricacies of your situation. I'd love to hear more.
Excellent. Thank you for that. We're going to pause for a second. Are there any final questions for this particular moment of the presentation, asking Tim specifically? I'll give you all a moment to think. Otherwise, we're going to shift gears slightly and hear from DSA, and they will give us a 10-minute presentation or so on the fight here in New York State. And then we will have time for Q&A after that. So if you do have a question that's burning, it can also come after the DSA presentation. So I'll give you all a second to think. I think we can shift gears here a little bit. Scott, do you have the slides?
Yep, just a moment here.
Great. And we're going to welcome Ben and Alice.
Yeah, can everybody hear me? My name is Ben. Hello. Great. All right. Yeah, thanks for joining us. And thanks, Tim, for the great presentation. Thanks to the Crown Heights Mutual Aid for having us. And hello to my neighbors. I'm a resident of Crown Heights, very glad to be here. I'm on the organizing committee of the Healthcare Working Group in New York City DSA. We're going to talk today about some of what we're working on the state level here in New York City, how we've been going out and talking to our neighbors, trying to get people part of that mass movement demanding single payer and a broader, program of health justice that Tim was talking about. I think we'll be able to address some of the questions or at least get closer to some of the questions people had about some of the specifics about strategy. So looking forward to that. And what else should I say? Oh, solidarity to whoever said they were type 1 diabetic. That's part of how I personally got involved in this work. Being someone with a chronic illness in this country is pretty sucky. So yeah, that's, everyone has a reason to be involved. So I'm glad that you're all here and are joining us for this presentation. So, all right, let's move to the next slide. I'm going to talk about our campaign that we're most invested in right now, which is the New York Health Act. So what is the New York Health Act? The New York Health Act is a single payer plan for New York State. So this is single payer on the state level. People were asking about the feasibility of Medicare for All right now on the federal level. We absolutely work to achieve that in DSA, including in New York City DSA, and we absolutely support that goal. But we also tack back and forth between the federal and the state level. There's a hell of a lot that actually Albany can do. We'll talk about that in a bit. I'm going to hand it off to Alice midway through this so that she can talk more about the sort of the how. But for now, I'm going to talk about the what. So what is the New York Health Act? As I said, single payer plan. It has several different components to it. Universal coverage. So every New York resident, regardless of immigration status, obviously, ability to pay, anything like that. Anyone who lives in New York and is a resident would be enrolled, including those who work in New York but live elsewhere. So for instance, if you commute, across state lines from Connecticut and you work here full time. New York Health Act covers all medically necessary services, so it's comprehensive. Existing Medicare, right, doesn't cover things like dental or vision, hearing aids. This is expanded and improved, right? Medicare for All on the state level. So it also includes things like mental health care, long-term care, which is really a big one, and gender affirming healthcare as well. Just like on the federal level, as we've heard about single payer, the scare tactics, right? It would eliminate private insurance, and with it, the tiered healthcare system in which the wealthy get access to superior services. So it equals the playing field, creates one big risk pool that, kind of like Tim was talking about, can bargain down the prices of things like prescription drugs and different services. The New York Health Act has no more network restrictions. You can visit any provider. There's no such thing as a network, right? And so that's another barrier that's taken down by this bill. And so that medical decisions will be made between a patient and a doctor. So really just a full frontal assault on the private insurers who stand right now right between us as patients and the healthcare that we need. Let's go to the next slide. So a bit more about the bill. One of the reasons why we know that it's popular and we know it has a lot of support is that New York State as a whole would actually spend less in healthcare costs under the New York Health Act than it does currently. And there are some startup costs, but over the long haul, it absolutely saves money to the state and to 90% plus of New Yorkers. That is all but the very, very wealthy will pay less in taxes under the New York Health Act. There are two taxes that are progressive that help to fund the health plan implemented under the New York Health Act. One is a payroll tax, and then there's a tax on non-payroll income, such as interest, dividends, capital gains. So taxes on wealth, not income. And then also, when we say it's free at the point of service, we mean that, when you go to see a doctor, when you go to get an operation, whatever, there are no fees. There's no cost sharing at all. There are no premiums, on your plan. There are no deductibles, no co-pays. There is an out-of-pocket maximum for prescription drugs. I believe that's something like $200 or $250, per year, and that's really it. Other than that, it's these two taxes. So it's economically sort of rational from many different points of view, including that of many small businesses, for example, which in the Democratic Socialists of America, we're not typically keen on representing their point of view, but I'm just making the point that it has very broad support. And Alice is going to talk in a second about what we're doing to win it, but I just want to underscore before she does that there was a question brought up about again, feasibility of passing this kind of legislation on the federal level, and the reason why we're so focused on the New York State level in this bill right now in Albany is that it's already passed in the Assembly, the lower house in the state legislature, several times. And we now there's a Democratic supermajority in both the state Assembly and the state Senate. Not to mention the fact that we really do have the most progressive state legislature here in New York that we've had in a long time, and certainly the most progressive in the country at the moment, which may not be saying as much as we'd like it to say, but that is something. So this is really an opportunity to strike while the iron is hot. So to say a little bit more in depth about that, I'm going to turn it over to Alice, and let's move to the next slide.
Great, thank you. Can people hear me okay? Yes, let me know if you can. Okay, awesome. So yeah, when we talk about what we're doing to win it, we're talking about the New York City DSA Healthcare Working Group, and we're part of a coalition of many organizations, groups of people who are working on this. But the work that we're primarily doing with the DSA here in New York, first is talking to our friends and neighbors about the New York Health Act. We want to be building a base of support. And so this has involved a few different strategies. So that involves phone banking. We have a regular tabling operation. If you've been at Grand Army Plaza Farmers Market, or you've been by the Parkside entrance to Prospect Park, we've been, talking to people there. I think what we find is that a lot of people believe that healthcare is a human right. A lot of people believe in single payer, and a lot of people just have no idea that the New York Health Act exists, or is actually like a feasible way of getting universal healthcare in New York State. So a lot of this is just, talking to people very regularly. We're also working on putting pressure on key elected officials. So that includes senators and assembly people who have either sponsored this in the past and are no longer sponsoring it, have not sponsored it yet, or are co-sponsors and are not really doing that much to get it done. So we want to make sure that they feel the pressure from their constituents that, we're the people who gave you your job and you have to, do the things that you promised to do. And that also includes Carl Hastie and Andrea Stewart-Cousins, who run the Senate and the Assembly, because they kind of have a lot of say in kind of what happens. So we want to make sure that this is a legislative priority in the upcoming session. We're also working right now on building coalitions with union members who believe in the importance of single payer organizing. So I think the issue of labor support and of union support came up in the questions before related to Medicare for All. We do see similar issues related to the New York Health Act. Basically that, we fought really hard for our benefits. We don't want to lose them. But I think the reality is that the New York Health Act is better for workers, both union and non-union workers, than any kind of private health insurance scheme that we have. And so we're trying to make sure that we have rank and file union members on board with what we're doing and voicing that support. We're also working with socialist elected officials and candidates for office to help them push for healthcare policy reforms, including the New York Health Act, and ensuring that they use their platforms to fight for health justice. So that involves working with state legislators who, actually will have the ability to, they and their colleagues bring this to a vote and make this happen. But it also means that something like a city council race, making sure that city councilors are aware of and fighting for health justice issues. We want to be involved in that and make sure that that socialists who are running for or who are in office are using their platforms to speak to health justice issues. And then we're also making sure that we're acting in solidarity with local fights for health justice. If you saw me, then you might have seen me nodding my head off when Tim was saying that if we build solidarity, we build power. And I think this is extremely true. The healthcare system as it exists fucks over everybody, but it does so in different ways. And there are people who are severely disproportionately affected, particularly in New York City, Black communities and communities of color. So if you go to the next slide, I'm going to talk a little bit about one of those fights. So basically in New York, hospitals that primarily serve people with low income, that serve Black communities and communities of color get paid less money for providing the same services. This has to do with Medicaid reimbursement and with the fact that a lot of times money that is supposed to go towards reimbursing hospitals that primarily serve low-income people ends up in the pockets and the offshore bank accounts of the executives of the large private hospital systems. So that basically means that it's not profitable to be a hospital that provides critical services to low-income communities. And rather than the state actually funding these hospitals, making sure that they can continue to exist and serve the populations in their area, Governor Cuomo has been involved in a kind of long campaign of closing and consolidating these hospitals. Generally, we see thousands of hospital beds leaving low-income areas and not being replaced with any kind of inpatient care. This is dangerous at any time. Like you need access to hospital services, in case you need to be in a hospital. But obviously, it's particularly dangerous during a pandemic. And so that's what we've seen play out in New York is that there haven't been enough hospital beds and haven't been enough services available, and it's killed people. It just quite frankly has been the reason that more people died of COVID than should have. And so we we saw this happening at Kingsbrook Jewish Medical Center, which is a safety net hospital in East Flatbush. And it was scheduled to close last year, which would eliminate 200 inpatient hospital beds. That got moved to December 31st, AKA at a point when COVID was spiking and at like an absolute dangerous point. luckily, through the efforts of local residents of East Flatbush, healthcare workers, a coalition of activists, that closure was postponed, but it has not been canceled. And so at this point, the New York City DSA is working with that coalition to make sure that this closure doesn't go through. So it shouldn't happen during a pandemic, but it shouldn't happen at all. We shouldn't be eliminating hospital beds that people need. At this point already, the access to hospital bed in Brooklyn, it's about 1/3 of what it is in Manhattan. So like per capita hospital beds is about 1/3 in Brooklyn. So basically what we've been doing, like our primary efforts have been kind of making noise about this. We've been holding phone banks. There's going to be some kind of like probably action around this, and we want to make sure that we get people involved. So I put the QR code there. That's just how you can call your state legislators, including Cuomo. It'll give you a script. You can leave some angry voicemails. It's a good way to get some energy out. But also if you are interested in getting more involved, then you can join with the healthcare working group and with that coalition. So if we want to go to the next slide, I'll just talk about some ways that we can have people plug in. This QR code is for the kind of link tree here so that you can, and I'll post the link in the chat as well. But basically, these are some ways that you can get involved with this fight. So one thing is just joining our healthcare working group, and specifically our Central Brooklyn field team. So if you're located in Crown Heights, you can join our field team that does tabling, phone banking, and events that relate specifically to people in Central Brooklyn and the healthcare issues that people in Central Brooklyn are facing. So there will be a way in there to sign up for the group. And then there will also be a link to call Assemblymember Carl Hastie and Senator Andrea Stewart-Cousins and demand that they make the New York Health Act a priority during this legislative session. So there will be a script for that as well, and a way to just let us know that you've made that call so we can keep track of it. And then also there will be a link to call your state legislators to demand an end to the Kingsbrook closure. Again, so that's like the QR code from the last slide. There's also a link to that there. I think, you know, these phone calls are like really great to do, and it's like a pretty easy way within a few minutes to have an impact. But if you're interested in getting involved in these longer term efforts, we'd also really encourage you to come to our meetings and talk to us a little bit more. So I think that's the end of our presentation, unless you have anything to add, Ben.
No, that was great, Alice. I think just, you know, if people have questions, we'd be happy to answer them either now or I guess, you know, later on over email. I'll put in the chat the place to reach us by email. Yeah, that'll just take 1 second to type. And the other thing is on the Kingsbrook campaign, I mean, I think it would be great, you know, just as a proposal sort of vaguely to throw out there, if Crown Heights Mutual Aid wanted to like co-host a phone bank with us to reach out to people to get them to call, especially once we have a notion, and Alice probably knows more about this than I do, but of when there might be some kind of action and press conference to draw attention to that struggle. It would just be great to get as many people out as possible.
Awesome. Thank you all so much for that. I mean, that, especially with Kingsbrook, that really hits home for all of us here in Crown Heights. So yeah, folks, if you have any interest getting involved or getting more information, like Ben and Alice both said, please follow up with them. I want to leave Stack open here for the next few minutes or so. We're scheduled to end at 3:15, but if folks have burning questions that they want answered of either speaker, please do so now, and we can have that dialogue go as long as folks are willing to ask and answer. So open Stack. I have one question that perhaps was mentioned, but maybe I missed. Are there any upcoming dates in particular that we should put on our calendar? Any crucial legislative votes? I know we don't quite know about Kingsbrook, but anything that we should put on the calendar right now and think about organizing toward?
Alice, you unmuted yourself, so I'll let you go.
Yeah, I guess we don't know when the New York Health Act will come up. We expect it will be after the budget. I know the New York City DSA generally is also working on a kind of huge proposal and a group of bills to tax the rich, which is an important part of this. As we mentioned in our presentation, like the New York Health Act ultimately saves money, but it is a big upfront cost. And also, like just austerity is bad for people's health. So kind of regardless of whether New York Health Act goes into place or not, we want to make sure that the rich are being taxed to fund the programs that people need for education, for housing, for for all of these things that obviously like play into each other. So I don't have the date for when the budget is voted on, but I do know that like that's kind of like a big point at which the DSA is organizing toward. And I think while we're going to be talking about the New York Health Act a lot building up to that, the kind of fight for the bill specifically will likely happen kind of after the budget happens, which is in about 2 months, but I don't have the date.
Great, thank you. So it is 3:15. I want to thank everybody who came out today, and specifically to members of Crown Heights Mutual Aid for organizing and hosting. We welcome and encourage everyone in the neighborhood to join CHMA and join your neighbors in helping us all survive and organize against this ongoing crisis. We have orientations every Sunday at 6 p.m. and you can sign up through our volunteer forum, which I'll post here in a second. And you can also follow us on Instagram and Twitter. This is where we post some links in the chat. Thank you, Scott. You can also find out more and connect with DSA's healthcare campaign, as mentioned, by emailing them or following them on social media. Links will be dropped right now. And if you have any questions here, feel free to ask them of either speaker. This is a great time to get all your questions about the nuts and bolts of healthcare and movement organizing answered. Oh, great. Greg, how can residents, nurses, and other healthcare workers use the essential nature of their work to leverage change and demands surrounding Medicare for All, New York Health Act, and other health justice measures without compromising patient care?
I'd be happy to take a shot at this, and I'm sure either Tim or Alice may have more to say. But a really crucial part of the coalition pushing for single payer on the state and federal level right now, is healthcare workers themselves. So the biggest union backing single payer in New York State is the New York State Nurses Association. We also have 1199 SEIU, health, hospital workers as well. And concretely, some of the things that physicians and PAs and nurses are doing are first of all just going on record, right, being public-facing advocates of single payer and talking about the conditions of their work, about their industries and why healthcare provision is so fucked up from the provider standpoint, not just the patient. And that's also just to the extent that they're unionized, also getting their unions to take an active position in favor of lobbying for this bill. Unfortunately, with Kingsbrook, I would say just another, because that also has to do with health justice, right? It's a hospital closure. Unfortunately, the NYSNA actually is not supporting, that struggle just because this was a deal that was worked out over many years. There's a lot of kind of backroom stuff that went on. But, I will say a lot of the nurses and doctors who are on staff there, nonetheless, are really helping to lead this fight to stop the closure, including the New York Doctors Coalition, which is a great group of progressive physicians who wanted to mobilize to stop this as well and tap into their networks. So, it's really crucial, I think, in on every level, just to have that kind of support from healthcare providers.
Excellent, thank you. And Scott just dropped some social media links for everybody to follow.
I have one quick thing to add.
Yes,
Scott,
please. Thank you, Tim.
Which is that, like, one of the most effective things I've seen happen right now with Medicare for All organizing is provider to provider organizing, provider conversations, right? Because like I think it's going to happen with it's happened every time this has come up is that the AMA says, oh, this will kill your healthcare. This will make socialized medicine will be the death of America. You know, this will destroy your patient care. This is bad for doctors. And the only way to really counteract that is to have doctors say, no, that's wrong. This is important. This is crucial for our care. And a lot of doctors just don't know. Generally speaking, of doctors I've talked to, most don't not support Medicare for All. They just don't know about it. They don't know what to talk about. I've talked to doctors literally while I was having surgery about like a couple months ago about Medicare for All, and he just didn't know like what the deal was or how finances work. They kind of are divorced from these things because they are insulated from, especially at like bigger hospitals and more corporate places. They're insulated from the actual like patient experience as far as health finance goes. So if you're a provider, talk to providers. If you're a med student, talk to med students. Like really hammer home as soon as you can, as often as you can. This is a political profession, and your actions have political consequences. Yes, and great, as I pointed out, great organizations are PNHP, Physicians for a National Healthcare Plan. They're essential, they're great, and SNP, which is the student version.
Awesome. Thank you so much. Thank you very much to Tim for being here today. Thank you to Ben. Thank you to Alice for also coming through and sharing what's going on with DSA and the campaign for single payer here in New York. Thank you all for showing up too on a beautiful afternoon and having this conversation. We all think it's super important, and clearly you do too. So this is excellent and encouraging. If there are anything else that people want to add, feel free to drop a link in the chat. We will also be sending around a feedback form, and you can ask some questions there and find out other ways to plug in as well through the feedback form. Takes 1 minute. There you go. Thank you, Scott. And other than that, any final words, Scott?
No, thank you all so much for coming. We hope that we can do more stuff like this in the future, not just about healthcare, definitely about healthcare again in the future, but about specific subjects, and keep it all under the CHMA working group umbrella. Thank you guys so much. Yeah, you guys rock. Thanks, everyone. See you later.
Thanks.
Thank you.